Hello again, and welcome to our 5th webinar of the Ariadne Labs Implementing Checklist for Quality Improvement series. My name is Francine, and I'm facilitating the webinar session today. If you have any questions or comments at any point during the webinar, you can either type them in the chat box on the right-hand side of your screen or use the raise to hand icon, and we'll call on you so you can ask your question out loud. Depending on your computer type, the screen might look slightly different, but all of the chat and Q&A functions should be situated on the right-hand side of the screen, as well as the hand icon. It just looks like a little hand waving, and that's probably under your Participants tab. If at any point you have any technical questions or concerns, please use the chat to host functions, and we'll assist you directly. I'll hand it over now to my colleague, Emily Benatti.
Great, thank you very much, Francine. Hi, everyone. My name is Emily Benatti, and welcome to Ariadne Labs' 5th webinar of the WHO Safe Childbirth Checklist Implementation Pathway Series. We are pleased that you're joining us today for what we're sure will be an informative and interesting talk on monitoring and evaluation. It's nice to see that so many of you have been able to join us today, and we look forward to being able to also answer any questions that you may have during our Q&A discussion at the end of the webinar. So today's presenters include Jonathan Gass, Ariadne Labs Monitoring and Evaluation Specialist, who will provide us with a background on M&E, what it is, and how facilities can set metrics and provide feedback. We are also delighted to have 2 colleagues describe their personal experiences with M&E in the field. So we will hear from Pinky Maji, who is a Senior Manager in Implementation and a member of the Better Birth Program and Population Services International in Uttar Pradesh, India. And we're also welcoming back Dr. Leonard Kabungo, who is a Senior Medical Officer at Gobabis District Hospital in Namibia. So to provide you with some background, Ariadne Labs is a joint center between Brigham and Women's Hospital and the Harvard Chan School of Public Health in Boston, Massachusetts. We have experience implementing checklists for quality improvement, such as the Safe Surgery Checklist, the Safe Childbirth Checklist, and the Serious Illness Conversation Guide. So through those tools, along with other projects, our mission is to build and support a community of researchers and practitioners who create and drive scalable solutions that produce better care at the most critical moments in patients' lives everywhere. And during this webinar series, we have drawn on experiences across our programs to share lessons learned in implementation, adaptation, and coaching. So to recap on our past webinars, in our first webinar, we introduced the WHO Safe Childbirth Checklist and its origin, as well as briefly presented participants with the implementation pathway as seen here. So through conversations with implementers, we found that implementation of the checklist alone is not enough, and that the steps listed here in this pathway are critical components for successful implementation and sustainability. And for those of you who are joining the webinar for the first time, I'll provide you with just a brief background on the WHO Safe Childbirth Checklist. So as many of us know, childbirth is really a complex process, and it can be difficult to remember everything that needs to be done. So checklists can be a way to remind oneself of what to do. And checklists have been proven to really be successful cognitive aids in other industries such as aviation to promote both quality and safety. So in 2012, the WHO Safe Childbirth Checklist collaboration was established, and it facilitated the sharing of experiences around checklist use across 234 sites in 29 countries. So this checklist is an organized list of essential evidence-based practices to improve quality of care and reduce maternal and newborn harm. And the Safe Childbirth Checklist is comprised of 29 essential birth practices and 4 pause points, as you can see in that image along the bottom of your screen. So on admission, just prior to delivery, within 1 hour birth, and then before discharge. Also in this first webinar, we heard from Dr. Kabungo, who, as I mentioned, joins us again today to hear about his experience implementing the Safe Childbirth Checklist in Gobabis, Namibia. During our second webinar, we discussed the engage step along the implementation pathway, where participants learned about how to engage with and interact with their leadership team, how to adapt the checklist, ways to conduct a needs assessment, and the importance of building an implementation team and identifying a champion. So for that webinar, we heard from Drs. Palladino and Berry, both from Ariadne Labs, as well as Dr. Rosemary Ogu, who is an obstetrician gynecologist based at the University of Port Harcourt Teaching Hospital in Nigeria. And then after introducing the WHO Safe Childbirth Checklist and learning how to engage with stakeholders, our third webinar addressed the launch portion of the checklist implementation. So during that webinar, we shared practical tips for how to launch the checklist through a participatory event, how to address possible challenges faced when holding this event. And to better understand this process, we heard from two implementers in the field. The first was Tunis, who is a team member from Banda Aceh in Indonesia. And we also heard from Jimena Villar, a research and M&E coordinator based in Chiapas, Mexico. So both of those individuals shared lessons learned about engaging stakeholders when deciding to implement the checklist in their facilities, as well as some of the obstacles that they face and how they tried to overcome those obstacles. And then finally, during our last webinar in December, we began to discuss the support portion of the implementation pathway. So more specifically, we focused on coaching, which we believe is a critical component when deciding to implement the WHO Safe Childbirth Checklist. So during this webinar, we discussed what coaching is and is not, how to decide when and how to coach, how to give feedback, and then we concluded with an interactive practice discussion. So for that webinar, we heard from Dr. Kulita, who is a senior program manager on the Better Birth program and also with Population Services International, and R.T. Singh, a program manager who is also with Better Birth and Population Services International based in Uttar Pradesh in India. We also heard from Jeff Durney, who is a senior program manager at Dana-Farber Cancer Institute in Boston, Massachusetts, and he led us through that interactive practice discussion. So that brings us to where we are today along the implementation pathway. So today we are going to focus on another aspect of the support phase where we will discuss measurement and data feedback. So as I mentioned, we will hear from Jonathan Gass from Ariadne Labs, who will provide a background on M&E, some examples of setting different metrics, and how to engage with data for feedback for ongoing learning and improvement. And then again, we will hear from our two implementers in the field, Pinky Maji and Dr. Kabungo. So before we really dive into the meat of today's webinar, I wanted to take a brief pause and hope that you'll take the opportunity to answer this poll so we can get a sense of what you're hoping to learn from today's webinar. And that poll should be open now for you to respond.
All right, we have about 20 more seconds until the poll will close. All right, Emily, so the results you should see on the screen.
Okay, great. So thanks to everyone who responded. So it looks like a lot of individuals today are really hoping to just get a general background information about monitoring and evaluation, understand some different methods for data feedback, and then also it seems like people are particularly interested in hearing how other implementers have effectively applied the M&E step in the implementation pathway. So hopefully we can answer some of those questions in the coming slides, and if not, we certainly look forward to answering some of your questions during that interactive discussion at the end of the webinar. So just again, as I mentioned, we're first going to provide that introduction to monitoring and evaluation, and then hear about 2 unique approaches to M&E and wrap up with the Q&A session. So I will now hand it over to my colleague, John.
Hi, everybody. Thanks for asking me to speak today at this webinar. I think all of you have a range of experiences implementing the Safe Childbirth Checklist. Some of you have started, some of you are planning to start, and I really think this is very timely to have a discussion about monitoring and evaluation approaches as it applies to checklist implementation, because we always encourage folks to think about this in the beginning phases. However, if there are folks who have already begun implementing, it's not too late. So first, I'd like to just get some definitions out of the way here. It's important to define what we mean by monitoring and evaluation up front, especially as these relate to checklist implementation. So monitoring means that we're measuring checklist implementations in an integrated and ongoing manner to provide your program with information on the progress of your activities. By this, I mean that your measurement must be systematic and focused on quality improvement. For example, in any checklist implementation, it's important for you to monitor the rate of checklist use among your clinicians. So your numerator would be the number of checklists used over the denominator of total deliveries in a given time period, for example. By evaluation, we mean the systematic examination of an ongoing or completed program to understand its effectiveness, efficiency, impact, or sustainability. Evaluation activities can also help understand why something is or is not working. For example, maybe 3 months after, after 3 months of implementing the project, it might be good to measure how adherent clinicians are to each of the checklist best practices. Adherence to some practices may be easier to change, while others might be more difficult to change, and this is something you might want to evaluate. You may want to consider measuring indicators such as this to better understand your implementation. So we'll discuss some strategies today about how to do just that. So why monitoring and evaluation are important? So monitoring and evaluation activities are important because you need to know if people are doing what you want them to do. This is the monitoring aspect of your work. And also if it's having the result of, that you're looking for, and this is the evaluation aspect. Many programs around the world conduct implementation work without looking into their data until it's too late. So we encourage implementation teams to utilize monitoring data to learn about their processes, as well as barriers and facilitators to successful implementation. Additionally, you cannot improve what you do not measure. And the only way to do this is to consistently and thoughtfully measure progress towards your goals. Monitoring and evaluating our work is also the only way to keep people accountable for their work, to capture lessons learned, including successes and challenges, and to feed these results back into the program for quality improvement purposes. I think that often we focus far too much on challenges and failures as they relate to our implementations, but it's also really key to celebrate your successes. And we encourage you to do that with your data. Share your data with your team. By doing this, you place value in the data so team members receive and internalize feedback, whether it be constructive or positive. So what data should you be collecting? First, the data you collect should be aligned with your overall programmatic objectives. There are generally 2 types of measurement that we refer to. The first is routine measurement, which focuses attention on indicators you will want to measure continuously throughout the implementation of your checklist work. Then we also refer to something called targeted measurement, which is meant to elucidate specific questions or hypotheses that you might have during your program. Keep in mind that your measures can be of your activities or of their intended results, which include 2 types of measures, which we refer to as process and outcomes measures. Process measures are metrics related to what needs to happen, or in other words, measurement of the activities you are conducting themselves. Some examples of this might include measuring the number of checklists that are filled out for all deliveries in a given time period, or, for example, measuring the number of fully used checklists versus those that are filled out only for certain pause points. This, for example, will help you to identify where the checklist is being used and where it is not, at which point you can assess any barriers to utilization that might exist for certain elements on the Safe Childbirth Checklist. Outcomes measures are metrics related to what you hope to achieve with your program. In other words, measuring the results or the impacts of your activities. Some examples might include capturing facility-based neonatal mortality pre- and post-intervention to assess your impact, or conducting interviews with your staff to gather their perceptions on barriers to checklist adherence. Needless to say, there are a multitude of process and outcomes measures for any checklist implementation, so choose wisely and prioritize those that will uncover the evidence you will need to improve your program and determine its ultimate success. Now I'd like to talk a little bit about setting metrics. As I just stated, there are many aspects to any checklist implementation that can be measured in a variety of ways. It's important that you keep in mind a few things when setting your metrics. First, you can't measure everything. I had a mentor who told me early on in my career that if you want to measure 10 things, you should cut that down by 50% and just start with 5, because it's more important to measure 5 things comprehensively than to measure 10 things with low quality. It's also important to design your metrics up front prior to launching your implementation. For those of you who are already deep into implementation, I suggest you take some time to discuss what you have learned so far, even anecdotally, these are also data, and determine a few metrics that you might want to pilot at this stage. The reason why I suggest these be determined up front is that it reinforces the importance of data and data feedback from the beginning. It ensures that you have longitudinal data about your project, and it ensures that you will have data with which to make evidence-based decisions as you proceed. Thirdly, because processes inevitably change, you must learn from and adapt your measurement strategy as you implement. This point also stresses the importance of using your data in real time to inform programmatic improvement. Some indicators will rightfully seem important at first and might become less important as you implement this work. There's also a concept of need-to-know versus good-to-know indicators. I stress this point because time, resources, and energy will be spent to implement your checklist programs. So it is vital that we focus on the information that you actually need to know. Once you have these down, of course, it's fine to start exploring the universe of metrics that could be collected, or the good-to-know indicators. Many of you may have heard this before, this term of SMART indicators, but I'd like to go over that now. There are 5 elements of what we call a SMART indicator, which I'd like to go into in detail as a guideline that I suggest you use when developing your measurement strategy. So indicators should be specific. This stands for the who, what, where, when, and how. So for example, patients, that's the who, delivering, that's the what, at a district health center, that's the where, who were observed for all pause points, that's the how, in the last week, when. So make sure that all of these elements are included in the indicator. It just makes it more specific and easier for people to interpret. This is followed by measurable, meaning the indicator has the capacity to be counted, observed, and analyzed. For example, the percentage of clinicians trained to use the checklist. So we know how to calculate the percent, and therefore we're able to get this. Additionally, indicators should be achievable, which means that the target should be realistic, and this is an important one. For example, it might not be realistic to reduce facility-based perinatal mortality within the first week of your program. Make sure that you set a metric that is achievable. Maybe you want to look at mortality in a 6-month period, for example, if you don't have a lot of mortality at your facility at baseline. This is followed by relevant, which means that the indicator should be a valid measure of the process or outcome. For example, calculating the percentage of implementing clinics with purple walls might not be entirely relevant. And finally, your indicators should be time-related. For example, the number of checklist trainings conducted in the last quarter. And I've listed here some process metrics examples, and I'll just maybe highlight one in each of these sections. So for checklist use, the first one, you might calculate the % of birth attendants using the checklist in the last week. And this might be something that you'd like to return to at weekly meetings to review with your staff. And we'll talk a little bit about data feedback in a minute. Another example under the second bullet of monitoring of checklist practices might be calculating the % of total checklist practices conducted by clinicians in the last week. So are all women delivering being seen for all pause points on the checklist, or are only certain pause points being monitored by your clinicians? In the third bullet, related to supply availability, I've highlighted % of deliveries in which the neonatal bag and mask was prepared at the bedside prior to birth. This might allow you to identify barriers to preparation of certain supplies at the bedside prior to delivery. As for outcomes metrics, the obvious of these would be to measure maternal and neonatal facility-based mortality. Many of you have, registers that are, or electronic systems that already monitor these data, and so compiling them should not be too difficult. You can also measure post-discharge outcomes or events, but this is much more of a challenge. Many facilities that we work with around the world have quite a bit of difficulty following up patients after they leave the facility's doors. But I encourage you to think of other outcomes metrics that might be worthwhile. And we often think of these as proxy outcomes measures, because while they don't tell you anything about reductions in mortality at the patient level, they still provide a significant level of information related to the impact or success of your program. So for example, it might be worthwhile to interview providers and get their perspectives before and after the intervention. What do they think of it? How's it going? What are the barriers? You might also conduct surveys, either at the patient level to assess their satisfaction with the care that has been provided, or surveys related to provider confidence or competency related to the elements of the checklist. You might also measure the % of women who return to the facility for postnatal care, or the % of women who return to the facility for subsequent deliveries. Now, these are just some examples. There's probably countless others, both process metrics and outcomes metrics, but I just wanted to highlight a few for you there. So next, I'd like to talk about how you should collect these data, or how can you collect these data. I encourage you to determine a team member who is responsible for data collection and reporting, or distribute these roles to multiple members of your team. You must also establish a frequency of data collection which is in line with the needs of your program and the metrics yourself. In-facility mortality data could be compiled monthly, for example, whereas checklist use, at least at first, might be more frequent while your staff get up to speed on the new tool. There are multiple data storage tools, including REDCap and Excel, many of which have their individual pros and cons. So choose the tool that you know best and what is most feasible given your familiarity and the resources in your setting. Select your units of analysis. For example, are you interested in patient impact, or is measurement that your clinicians are adhering to the checklist enough for you to determine that your program is successful? And finally, one of the most important part of any measurement strategy is to determine who will be the consumer of the results and how your data should be delivered to them.
Great. Thanks very much, Sean, for sharing that information on what data to collect and how, and then some metric examples. That was really informative. Thanks so much. So before we continue on to learn a little bit more about data feedback, I'd like to just pause again for a moment to have our participants answer another poll and learn about some possible barriers that today's audience might face when measuring their implementation. So that poll should be up now, and we'll keep it up for about 30 seconds.
All right, Emily, we have a few people that were able to respond to that, and the results are up now.
Okay, great. Thank you. So it looks like we have some varied responses, but just for a couple of examples, some people are indicating that they might not have the resources for some systematic measurement. There are other competing priorities for quality improvement at their institutions. Hopefully, again, we can try to address some of that towards the end of the webinar and moving forward. So I will hand it back over to John.
Good. That's some really useful information coming from the participants today that I think we'll reflect on now and also in the end when we get some questions from those that are participating. So one aspect of monitoring and evaluation that I think is often neglected is the fact that these data are being collected in order for us to learn. And so to build upon the last point, it's important that you learn from your data. In other words, that the data you collect should be utilized for the improvement of your programs. As I stressed earlier, there's no reason to measure anything if you're not prepared to make the necessary adjustments to drive improvement in your program. I've seen many programs that successfully collect data, but nothing's ever done with the data once they're collected. So even in small ways, the sharing of data in the form of reports or newsletters, posters, and other visualizations can be tremendously beneficial to you and your program. So just to stress this point a bit further, learning from your data in real time is key, or at least routinely, allowing you to understand what is working and what is not, so that you can make necessary adjustments in your programmatic activities before it's too late. The sharing of data with your team also establishes a learning environment. We learn and review the data routinely and grow together in the challenges and in our successes. Staff will feel part of the project when they are able to see that, let's say, oxytocin administration rates after delivery are increasing, for example. Or they can help you to strategize on the workflow and processes that must be in place to get the neonatal bag and mask prepared at bedside prior to delivery. So how should you go about doing this? There are many methods of feedback, including hand-drawn and computerized charts and graphs, or by sharing reports in meetings with your staff. One of the most successful implementations that I've seen had actually paper charts that they posted on the wall in the maternity ward, plotting in magic marker their successes on a graph over time. Sometimes the simplest visualizations are the most effective visualizations. Some have even displayed these in the waiting room at their facility to ensure patients are aware of the improvement activities that are going on at the facility. Many facilities I've worked with will present reports on their checklist data to facility administrators so that they understand the clinical and supply-related challenges that exist and so that they can allocate resources to filling gaps as needed. So that's the end of this presentation. I'm going to pass it off to Emily and then introduce our first guest for the day.
Okay, wonderful. Thanks again so much, John, for talking to us a little bit about data feedback, which is really an important step in your monitoring and evaluation process. So as John mentioned, now we're going to hear a little bit about just briefly the Better Birth Program, which John will describe a little bit, and then we will hear from our first guest speaker today, Pinky Maji, about M&E in India.
Okay, great. So as most of you are likely aware, for the last 2 years, we here at Ariadne Labs and at Population Services International have been implementing a large-scale randomized controlled trial of the impact of a WHO Safe Childbirth Checklist-based coaching intervention on maternal and neonatal outcomes in Uttar Pradesh, India. Specifically, we've observed upwards of 7,500 deliveries to understand adherence to evidence-based practices and over 162,000 mothers and their babies to assess impacts on morbidity and mortality among mothers and their babies. This project has been carried out in collaboration with a number of partners that you see listed on the slide. One such partner, Population Services International, was the program implementation team on the ground with over 230 staff who carried out both intervention and research activities in the trial. I'd like to introduce Pinky Maji, who is the Senior Program Manager for Implementation from Population Services International, India, who will share more information on the Better Birth approach to monitoring and evaluation. Pinky, take it away.
Hello everyone. Thank you for joining us today. My name is Pinky Maji, and I'm glad to be part of this webinar and share my experiences from the Better Birth program. A central part or component of the Better Birth program is that we coach birth attendants to facilitate quality improvement in the labor room through use of WHO Safe Childbirth Checklist. Integral to coaching is the ability of a coach to identify barriers, to change, and work with the team to determine a solution. Throughout this process, it is a real asset for a coach to be able to constructively share data with the team on key indicators and their progress. Today, I would like to share with you how Better Birth coaches have collected and shared data during the implementation of this program. Apart from peer-to-peer coaching, coaches spend time at the facility observing the birth attendant performing a delivery. During their observations, they assess whether the practices on the checklist are being followed or not. Coaches first capture the observation on paper, then they enter their observations into a mobile device through a smartphone application. This data is then uploaded to a cloud-based server. The Pulse system, which is a web-based platform, automatically generates visual reports and graphics based on this data. A green and red colorful report that we got heat map can be seen in center of the diagram of the slide. This automated reports are available in near real time. Coaches are then able to use this report in order to share progress and encourage change. The use of observational data has been very helpful in our experience. Let's take a closer look at the heat map in our next slide. Now, this heat map shows behaviors from the checklist in one particular facility. Each horizontal row indicates behaviors from the checklist, whereas each vertical column indicates the time when a coach was able to observe a delivery. The green color indicates that a behavior was successfully performed by the birth attendant. The red boxes indicate that a behavior was not performed. The yellow indicates a time when a coach had to prompt the birth attendant to perform a behavior. In this facility, you can see that the birth attendants were not preparing a neonatal bag and mask before each delivery. This is a critical supply for resuscitating babies unable to breathe. Through sharing this heat map during coaching visits, the facility staff were able to identify this persistent supply gap and advocate for the neonatal bag and mask to be made available and kept in the labor room so that it is readily available when needed. The Better Birth team communicates on progress at all levels. In this slide, I will take you through the various levels where data feedback happens for quality improvement. The first level of data sharing happens at the facility level. Behavior data, supply status, and qualitative information on successes and gaps are shared within the facility through one-on-one coaching sessions as well as through regular group data sharing meetings with all labor room staff, including the head of the facility and childbirth quality coordinator, who is the local champion, a proactive, dynamic, and well-respected facility staff identified by the team at the facility. The regular sharing of this data motivated the birth attendants and gave extra attention to behaviors which are deficient in the report. Also, they help in identifying various barriers like training needs, supply for non-exhibiting behaviors, etc. In the same context, I would like to give one real-time experience. During one of the monitoring visits, the birth attendants came to us and shared that how they have worked on the red boxes to ensure all barriers are addressed and there is improvement in behavior uptake. The next level of sharing happens at the district level. Better Birth organized district progress sharing meetings to increase communication between the district office and facilities in order to improve supply, training, and staffing concerns. When data is shared with the facility and district officials, it acts as a catalyst for evidence-based decision-making. It also drives a sense of competition and boosts confidence and motivation. We also try to empower the childbirth quality coordinator and the head of the facility to be part of these meetings. For example, in some districts, supply of vitamin K and oxytocin was a huge barrier in uptake of behaviors related to the supplies. These supply issues were taken up during district progress meetings to seek their guidance and intervention in solving these issues. Apart from facility and district level, data sharing is also done at the state level. Progress and data based on the behavioral uptake, supply status, and other operational and management aspects to coaching is also shared at the state level through quarterly progress sharing reports and various other forum meetings. This also helps to escalate certain supply-related issues which falls under the central procurement system of the government and needs guidance and intervention from the state. The data feedback loop has been found to be very effective in monitoring the coaching process and kickstarting positive impact through simple interpretation of color and qualitative description. Apart from gate maps, our coaches also provide feedback based on their observation through more creative methods as well. In the slide, on the left you can see that one of our coaches provides positive reinforcement in this poster by naming a champion for each of these important behaviors. Whereas on the right, one of our coaches, Shivangi, developed a poster which depicts a checklist tree. Each leaf represents a behavior, and over the time, the red and yellow at the root grows into green. Thank you so much.
Great, thank you so much, Pinky, for sharing that experience. That was really informative, thank you. And so next we will hear from our second guest presenter today, Dr. Kabongo, who will share his experience with monitoring and evaluation through a discussion with John. Great, so take it away, John and Dr. Kabongo.
So for taking the time today to speak with us based on your experience at Gobabis District Hospital in Namibia. We look forward to understanding more about your checklist implementation work. So I have a few questions that I'd like to ask. So first, I'd like to discuss your goals of the program that you implemented. What were the goals of this initiative to implement the Safe Childbirth Checklist at your facility?
Thank you very much, John, for the question, and thank you very much for everyone out there for listening to this webinar. I would say one of the main initiatives to use the checklist was to standardize our quality of care in the maternity ward, and to see the impact the checklist could have on our maternity outcomes, or maybe maternal and neonatal outcomes. So we know that we realized that our indicators were not good at the end of 2014. So we started thinking on what is the best way to reduce mortality in our maternity, what tools we could use to make a difference. And the checklist seemed to be a cost-effective way to see how we could have an impact on our outcomes. That was our first objective. And the second one was actually to have a measurable data available in our facility. We know that most of government hospitals, we have data that is collected through the health information system. But we wanted to have something generated through the maternity ward, because the data which is collected through the health information system is actually generated through it's collected through all the health centers and the clinics and the hospitals, and it's actually compiled, and it's very difficult to trace our own data and see our indicators indicators how they are doing. So it was also, we have been trying different methods to, like trainings and so on, to try to reduce mortality, but we wanted something which could act as a catalyst to effect the change, and the checklist seemed to be very, very helpful.
Thanks, that's really helpful. So you mentioned quite a bit about data. So next, I'd like to ask you about your monitoring and evaluation strategy during the implementation of this work. So what were the metrics that you collected while implementing the Safe Childbirth Checklist, and how exactly did you collect them?
So the metrics that we use were actually to try to see birth practice adoption, so as indicated on the checklist, from admission to discharge. So through the whole process of childbirth, we know that there are different things or different procedures that midwives or doctors have to accomplish for a woman who is in labor. But there was no system to track if midwife and doctors are doing the right thing, if they are actually doing these behaviors, if they are observing these behaviors. So we use a model of coaching, the head of the unit, which was myself, to observe how the nurses and midwife were doing, implementing the checklist. Then time to time, I will intervene and support them in understanding what they needed to do. So we also identified champions. So we realized that there are some nurses that were actually pushing through and really motivated to do more than others. So they were more empowered to coach other nurses. So we created a system of peer-to-peer coaching over time. And that's actually, we could also identify sometimes some gaps, and we needed to bring change by intervening and guiding and supporting what should be done. We would observe the practices, and then we record this data on the checklist. We also use the delivery register just to see and to compare our mortality especially, and also some of the other indicators that are not part of the birth program. For instance, if a woman delivered at home, she was not in labor in the unit, but she came after, so we needed to use the register to settle some of the discrepancies every week. So we compare this data with the behavior data for the checklist, and then we abstract the quality data that we needed.
Great. That's really excellent. So let's see. So as you heard during my presentation and earlier, we've discussed quite a bit about facilitators and barriers to measurement related to checklist implementation. So I'm curious to learn from you and your experience, if you can share with us what were some of your biggest measurement challenges?
So one of the biggest measurement challenge was establishing a data management unit. And we have, of course, a health information system, but the quality indicators that are in the health information system are very few. When you look at essential birth practices, what we are really looking at to see if staff are adhering to those practices, we don't have actually those indicators in the quality in the health information system. So that was a challenge. We needed to have a unit that could actually process that data, because it was actually a new system or new, I would say, new indicators. So we needed to have a database. There was no database for this new indicator, so we needed to establish a database to record this information. And we needed to identify also someone at the hospital who was good in data collection and computer skills. And we identified someone who was already doing other administrative work to add this on our scope of work. So she was actually very multi-skilled and doing checklists sometimes in the evening or in the afternoon and attending to our work during the day. So that was very commendable. And another thing was the data flow, because the data was actually generated in maternity ward. But the data was not remaining in maternity ward. We needed to transport this data from the maternity ward, from the remove the checklist from the maternity records to the data clerk for it to be entered. And after entering the data, we needed to store the data for future references. So we needed to establish a system, kind of a parallel system to the health information system which was there, and then to see on a weekly basis how progress we are making in this project. And challenges were many, of course, at the beginning, because it was about bringing about behavior change, because the unit and the district hospital and the management has one way of doing things. There was actually an organizational culture which has been there. So this was actually this brought a bit of challenge, and we needed to redesign, our organizational culture and bringing new ideas and a new way of doing things, and that was also a challenge. But we discovered some gaps in administration on the checklist. We would run out of some copies, for instance, during the weekend or in the night. Some of the staff will not adhere to the essential best practices, and we used to meet weekly, and discuss with the staff. Sometimes I had to come even in the night and sit with the staff at night and discuss their challenges about the implementation of the checklist, and give them my guidance and my support, and observe how they are doing it and support them and do it myself and show them how to do it. So this is the way we managed to go through those challenges.
Excellent. That's incredibly insightful.
Thank you.
One thing I think that you've highlighted for me is the importance that the checklist is not just a documentation tool, but also a tool to facilitate best practices.
Yes.
So how exactly did you ensure that the checklist was used with fidelity? That is to say, that the practices were not just done, but done correctly.
Yes, that's very important, because in the quality improvement process, we need to make sure that we adhere to the right practices so that we attain the quality we are looking for. First of all, we needed to have a coaching process in place to make sure that it wasn't just a tick and fly phenomenon. We have used the checklist before, the surgical safety checklist, when we started in the past. People just tick and then fly just to make sure that it's ticked, it's checked, but in reality it's not checked. So the checklist don't actually do the process. We needed to ensure trust, trust in the process, and also to bring up motivation that what we are doing is for their hospital, what the staff are doing is for the hospital, it's for their communities, for their patients. We needed to make sure that people got a passion and a love and commitment, and that could enforce actually fidelity to the checklist completion. So it goes actually beyond the phenomenon of tick and fly, but it's a whole process of behavior change that is coming with the checklist. We also used to do random checks to see what has been happening over the last 2 or 3 days, particularly during the night shift. Sometimes I would sit with the night shift, to discuss, like I said earlier, to discuss the gaps, and sometimes some checklists are missing, and then we try to find them, or we try to put some, to make copies and things like that. So they bring up their actually challenges, and then we discuss the way forward. We use also sometimes what we call visual audits, would also help to support and encourage the staff to do better next time, all the time. That's how it improved what we tried, and ensure that the checklist was actually used with fidelity.
Well, you've certainly done an impressive amount of work to make sure, that your implementation has been so successful. So can you tell us a little bit about what you've done with these data since collecting them, and maybe some of your future plans?
Yeah, so far a lot has been happening. So first of all, the data has been shared weekly with the staff when we are doing our staff meeting, and when we are doing the major rounds in the hospital, in the maternity ward. So the data has been shared also at the management level during the management meetings at the regional level, and also the data has been shared at the national level in the quality management meeting at national level, and also in some of the forums that are organized, gathering all the doctors of the country. We had a wonderful time and make presentations on what we have done so far in our hospital and share with the colleagues so that they can learn from best practices. And the data has gone also beyond Namibia. It has gone actually international conferences. We have shared this data in international conference on quality improvement. And right now, there is an abstract that has been written that will be shared in the BMJ Quality Series report very soon. Also, we are implementing the checklist now in other facilities. So far, in Namibia, 5 district hospitals, nurses across the country, especially those who have got high mortality levels. We have trained them, and then we have implemented, or we have introduced the checklist. And then so far, one of the hospitals actually started already using the checklist, and they have got actually preliminary data. So there is a national emergency obstetric care training, and what we have done is during that training, we actually introduced a database program. I mean, to introduce a checklist. So we have actually trained several staff around the country, and we have discovered that the checklist actually is like a reminder. When we train them on life-saving skills, and we train them on the checklist is like reminding all the time the essential best practices that they need to do, which is actually complementing already their life-saving skills. So far in Namibia, 6 district hospitals, nurses from those maternity wards have been trained in the use of the checklist. And one already has started using, collecting data and have shared data. So we are looking forward for more data to come in the future, and also for more hospitals to start using the checklist in Namibia. Thank you.
Excellent. Well, from myself and my team here at Ariadne Labs, I thank you so much for taking the time to speak with us today. You provided an incredible amount of both your experience and knowledge, and we look forward to hearing from your data soon when they're published in BMJ Quality. So thanks.
Thank you very much for the whole team, and thank you for inviting me to the webinar.
Wonderful. Thank you so much, Dr. Kabongo, for joining us again today and sharing how you approached monitoring and evaluation at your facility and how your efforts have really spread across the country. That's really exciting news to hear. Before we head into the Q&A session, I just want to have participants answer this last poll just to get a better sense of what additional information you might find helpful around monitoring and evaluation. So that poll should be up for about 30 seconds.
All right, about 15 more seconds. All right, Emily, those results should be up on your screen.
Okay, great. Thanks so much, Francine. So again, it looks like we have a range of responses, but it looks like participants are interested in how to decide which metrics are most helpful for their program and its goals, what to do with data once they are collected, and then again, how to effectively provide data feedback. So hopefully, again, those are some topics that we can cover in our Q&A session, which we will now move into. And I do just want to pay attention to time and see that we have about a minute left in the hour. But if individuals are able to stay to answer a few questions, that would be great. If not, we will be sure to post any unanswered questions and answers to the questions we're about to get to in our online portal, which you can find at portal.ariadnelabs.org, and become a member of the Better Birth community. If you do have any questions, you should be able to type them into the chat box on the right-hand side of your screen, and we can get to them then.
you'd like to also use the raise to hand function under the participants tab, we'll try to unmute your line if that's available for you.
Great, thanks. So it does look like we have a question from one of our participants, which is why not put the checklist on a smartphone and dynamically capture checks, timings, and other usage data? So John, is this something that you would like to discuss?
Sure, yeah, thanks for that question. Certainly, I think if your site has the resources to put the checklist on a smartphone and use certain data collection tools such as ComCare or RedCap to capture data in real time as you observe your clinicians utilizing the checklist, I think that's a great idea. As you saw during Pinky's presentation, she presented the heat map, which was displayed in green when behaviors were adhered to, yellow when a coach needed to prompt them, and red when the birth attendant was non-adherent to the specific checklist item. That was developed through a data capture and reporting system that we captured the data through ComCare, which is an open source application. So certainly I think that's a great idea, but I want to also emphasize that sites that do not have smartphone or Wi-Fi capability, this can also be visualized on paper charts and in routine feedback to staff. So thanks for that question. Are there others?
Okay, great. So, John, it looks like that there is another question somewhat related to what you were just talking about. This question is, you mentioned that learning from your data in relatively real time is key. Can you explain tips for how you can achieve this with limited resources?
Sure. So certainly utilization of online or tablet or smartphone-based data capture tools will facilitate real-time data collection and feedback. But I think that real-time data feedback takes resources which many sites don't have. So at a minimum, I would encourage teams to revisit their data routinely at predetermined time points as your monitoring strategy might require. So for example, maybe at weekly team meetings, you might focus on a different checklist item each week to monitor challenges to adherence to each of those items and to come up with supportive strategies in order to help your staff adhere to those over time.
So we have another question coming in from Maria asking, is there some information about when we're going to share information with WHO and between research groups?
So I'm not sure the response to this question, but certainly we can post it in the online portal later on. Maria, was there specific information you're referring to that you were interested in sharing with the WHO? I'll just give you a few seconds to our results. So I think you're referring to the results of the Better Birth trial that both Pinky and myself highlighted. Oh, no, you're referring to results from Mexico. So I'll wait for the core team members and Nabiha to provide answers to that question because I can't answer that today. But it is a good one, so we'll get in touch with you later on.
Thanks, John. And Maria, in terms of that, that's something that hopefully we can answer in the future, and we will certainly put that in our online portal as well. So I think we might have time just for one more question. So let's see.
So just to let you know that in terms of Maria's question, that Nabiha says that we look forward to sharing this information actually on a future webinar. So Maria, tune in for that information. And as for another question, how will some of the tools developed in implementation efforts to date be shared with others who are attempting implementation of the Safe Childbirth Checklist?
Yeah, so I think this is a great question, and I'll let Emily get into the specifics of how it will be shared with the group that are participating today. But just to emphasize that for me, monitoring and evaluation should not just be site-based. I think we can learn a lot by doing comparative work between sites and sharing with one another about our challenges and successes as we go. I know that I speak for Nabiha and myself when I say that as we continue to iterate on various implementation dissemination efforts, we will reach out to sites and continue to share those lessons learned so that all of us can, you know, benefit. Any other information on that, Emily?
No, great, John. Thanks very much for that. And just again to kind of reiterate from the previous question, all of that will hopefully be available at some point in the online portal, which actually I think because we're coming up on time, we will end this Q&A session and post any unanswered questions or add-ons to questions in our online portal, which you can see here. And in that portal, we also have the Safe Childbirth Checklist and the Safe Childbirth Checklist Implementation Guide available for download and for you to use in your facility. And then just in terms of next steps for this webinar series, the next webinar will be held in the coming months, and more information will be sent to you on that once we get a date solidified in a topic. And then again, you can find a number of different resources in the online portal, including past webinars in the series, and then this webinar and these slides will also be uploaded for you to access. So if you have any follow-up questions, please feel free to contact us at our email address at scc@ariadnelabs.org. And thanks again to everyone for joining us, and thank you in particular to Pinky and Dr. Kabungo for sharing your experiences with monitoring and evaluation at your facilities. Thanks very much, and enjoy the rest of your day.